So one thing that I like to kind of clear up and just make sure that we're all on the same page is talking about some nomenclature. There's a lot going on about understanding what is a paramedic, what are we called in the industry, what are nurses called, what is this ET3 thing, what are we thinking and talking about when we talk about what's the difference between a community paramedic in Colorado or a community EMT in Minnesota. So I just wanted to be able to define some of that for you. I'm going to first start by coming through and defining the difference between us in the United States and the difference internationally. So internationally, the term of paramedic, the EMS chiefs from around the world have come together to really rally around this nomenclature of the single term of paramedic, but putting the primary care paramedic, intermediate, advanced, critical care community, and then ultimately calling the service a paramedic service. Where here in the United States, we have an identity crisis, looking at what are we an EMT, advanced EMT, paramedic. When looking across states, community paramedics are called all different things in every different states, and looking at us as an ambulance service. So knowing all of that, I wanted to define some of that for you. I see a community paramedic is the provider of care, providing community paramedicine in their community. There are states, again, like I said before, that are community health paramedics, community EMTs, or community EMS providers. Those are all licensed or certified providers that work under the current scope of practice within their states and within their communities, serving those community needs. They can work independently or within their care team as their state has set that out in rules and regulations. Next, I want to look at mobile integrated care, healthcare. Mobile integration I see as a team of providers working together to care for patients in that at a hospital setting. It could be working with a nurse call center. It could be a co-response model with a paramedic, a traditional paramedic, and a nurse practitioner responding to the home. And it's just that mobile team. A lot of states are also embracing this integrated care model of an integrated practice. The practice isn't always mobile. So having that coordination of that care with those different care team members is also a different way to look at that. I do see that a community paramedic could be a part of that integrated care team or that mobile integrated health team. Lastly, I want us to look and define what this ET3 thing is. That's what I hear it said. You know, that ET3 thing that's kind of community paramedic, but it's really not. But what is that all about? It's the emergency triage, treat, and transport that allows, that the federal government has put forth through the Center for Medicare and Medicaid Innovation Center to be able to find a way for us to care for these patients and get reimbursed in a more creative manner. They're in the process of evaluating those applications that they received, but really the three main concepts of the ET3 is they want to transport, it's the three, to be able to transport to an ED or destination covered under current regulation, and all these items you would be reimbursed for. Second, transport to an alternative destination. And third, provide treatment in place where appropriate with an appropriate provider as designated a provider within your current state and practice, or through telehealth, or both. Again, really looking back at improving the quality and lowering the cost by reducing the avoidable transports to the emergency department and unnecessary hospitalizations. One last thing that I kind of want to add into that in looking at this is, as an industry, I think we need to look at who are we and how do we identify ourselves. Often in the community, when you see an ambulance going down the road, you ask the community who is driving that or who is in the four walls of that truck. And you will hear EMT, paramedic, or ambulance driver. Something I just want an example that someone gave me. When you see a red truck with lights and sirens on it, that's large with ladders on it, when you are asked who drives that, do you ever hear them say, that's a fire truck driver? Or if you see a car with lights and sirens, do you ever hear them say, that's a police car driver? So as we advance not only this idea of who we are as EMS, paramedics, community paramedics, etc., I think we need to look at how the outside is identifying us with this identity crisis that we have. So going on, I want us to go into just the different standards, such as the education and certification of what it takes to be a community paramedic. I think first, as we are going out into the community and interested in educating or starting a community paramedic program, the first thing you need to do is educate the community first about what is a paramedic, what is EMS. Again, they see us primarily as ambulance drivers. So what can we do to change that? It is sitting down and explaining to them that paramedics and EMTs come to the table with education and training to provide high-level care currently in an emergent setting. But now with this idea of a community paramedic, we can also do so much more. And so being able to educate them and the community about paramedicine and community paramedicine would be the first thing that we would ask for you to do. The second thing is to be able to educate the provider of care. You need to find that education institution and the subject matter experts to host this type of education that is different than your traditional paramedic education. And your normal paramedic training centers and your paramedic education and paramedic instructors, this is going to be a little different. So through the years, we've developed a national curriculum and we've worked with certification and done studies to be able to advance the education. The courses that we're seeing, we have 3 different levels of courses that are out there. We have what we call the technician level, which is to educate providers on alternative destinations. We have the clinician level that allows the providers to work independently within their current scope of practice. And then in the future, we have some universities that are looking to have a community paramedic practitioner with a master's degree. So talking just typically about the clinician level, it's around 100 to 300 hours of clinical and didactic time. And upon completion, they can sit for a board certification. The International Board of Specialty Certification, the ones that have created the critical care paramedic, the flight paramedic, tactical paramedics, has also created the community paramedic certification. A lot of our states that we've seen that are adopting this form of requirement are requiring the providers to take that college level clinical course and then pass the certification exam to be an accepted provider within the system and to be able to be reimbursed in the future. So now we have the need of what is in our community. We have the educated provider, but there's a couple of other little nuances to this. I think we need to understand the importance that this is an expanded role of the provider, not ultimately the expanded scope. Now, through legislation, some changes. Have there been some expanded scopes? Yes, but really what we're doing is taking the paramedic in their current practice, giving them additional education, focusing those areas on the community needs, and filling those gaps and working alongside other healthcare providers. So when I look about that, when I think about that, and I think about a community paramedic, they're in the areas of primary care, still in emergency care. They're working within along public health, disease management, prevention, wellness. We're seeing a big uptake in the mental health arena and even in oral health. So what are the steps and the things that you need to do going forward? What do you need to know? The first thing is you need to plan. You need to plan and create a work plan. A friend of mine said, like airway medicine, do you need to plan to ahead of time to ensure that that patient's going to be okay to establish an airway? Are you going to plan out all of your tools, all of your training, and everything that you need, of course you're going to. So let's do the same thing when planning out for a community paramedic. There's other things that you need to do to see if it's feasible, like adopting current legislation, working with your state EMS office to see what requirements are in place at this point. Can you even have practice as a community paramedic in the state? And working with those internal commitments within your own organization as well. There's could be a lot of pushback and people not wanting to be a part of this new change, but understanding and planning ahead of time and creating that work plan will help you through that whole process to lead through that culture change and communicate the progress of the program and ultimately lead to success. And then lastly, plan to connect with that college or university to establish that education. We currently have 16 states that have either enabled legislation and or have rules or regs in place for CP providers and services. There's one state and one group that I want to bring some attention to. In Pittsburgh, Dan Swayze is an associate VP working with a health plan in Pittsburgh with UPMC as a health plan. What they have done is they are able, because of the health plan has access to all of the patient's healthcare records, they are identifying where the needs are at the highest level. They're able to see every provider the patients see, every test that is done. So they've brought in this community paramedic concept to fill those identified needs and be able to help monitor and progress these patients through an appropriate path to wellness and decreasing illness, and ultimately setting up that population and this program to fill all those gaps. The next step that you need to do is you need to assess your community's needs. You need to find those right stakeholders, whether that's through different community needs assessments. I would recommend that you're working with your public health department. They do community assessments. Your nonprofit hospitals are required to do health assessments. A lot of all those stakeholders come together, look at the data, look at the needs in the community. We already have enough silos of the 4 walls around the hospital or the 4 walls around our ambulance. We need to break down all those silos, really look at the data of what the needs are and bring everyone together to say, what can we do to improve the outcome and fill these gaps and meet the needs in our community. An example where this has been done is in the city of San Diego. I want you to meet Ann Jensen. She's a resource manager that has been working as a community paramedic and leading the program as they identified that they had gaps for mental health services in the city. The program, before the program, the amount of patients going to the ED or calling 911 or disrupting the system as a whole, all just for mental health, because they're lacking mental health patients, was such a need that they looked to the city of San Diego to handle this. So because of that, this program has decreased ED utilization. They are now expanding this to other resources and other areas beyond San Diego, but the needs were identified in their community, and the community paramedics came in to fill those gaps, and it's been such a success.